Assalamu alaikum. This will be the second part of weaning from venoarterial ECMO. As we mentioned before, ECMO is a bridge therapy, it's not a destination therapy. Daily assessment for removal should be done. Why do we do weaning trials? As presence of full ECMO flow, we can judge the RV function. So when we decrease the ECMO flow, there will increase in the preload and enable RV function to be assessed. On other contrast, LV function preload will be increased and the afterload will be decreased. So at that time, we can see the suitable window for decannulate the patient. The question is how to do weaning trial. This question have several answers. No unique trial, no unique steps. There are multiple schools for a weaning of a VA ECMO. Some of them using transthoracic, some of them use pulmonary artery cath, some of them use transesophageal echo. And the target for all of them to search for the suitable window for weaning. But all of them agrees that the patient should be hemodynamically stable, mean arterial blood pressure more than 60 millimeter mercury, and with no or absent or low doses of vasoactive drugs, and pulsatile arterial wave maintained more than 24 hours, and good oxygenation of the patient is present. We will go now for the transthoracic echo guiding ECMO weaning. This is a method for Isawi et al. And the patient had the same criteria. Then we'll go for her method. In this trial, they use transthoracic echo to assess the patient LV and RV function on full flow and hemodynamics, like as we mentioned in the previous lecture. Here we will go for full flow. Then after that, in 10 to 15 minutes, they will decrease the flow to 66% of the flow. Then after 10 to 15 minutes, they decrease the flow to 33% of the flow, full flow. Then until they reach 1 to 1.5 liter per minute after 10 to 15 minutes. And every step, they assess all RV and LV function. They assess the hemodynamics of the patient, lactate level, and every steps and echo parameters through the transthoracic. And if the patient pass all these stages, they can go for decannulation. If there is a problem, they will stop at any stage and return to full flow. The second method of weaning, hemodynamic transesophageal echo, guiding the ECMO weaning. First, we will take baseline hemodynamics and LV and RV function baselines while we are on full flow. Then ECMO gradually decreased in increment 0.5 liter per minute till we reach half flow. And this measurement should be taken over at least half an hour. If any distension occurs, we will return the patient to full flow and abort the trial. Then the third step, we will load the patient with a volume of 10 ml per kg for 5% of albumin over 20 minutes. And this is used to achieve adequate preload over at least 1 hour. Then the measurement of RV and LV function is taken. And in step 4, loading inotropes like infusion of dopamine and milrinone for at least 1 hour. It should be given more times, especially for milrinone. At least they can give in 4 to 6 hours. Then the measurement of RV and LV function should be taken. And each step, if we have LV or RV distension, we should go backward to full flow. During any weaning trial, we have hypotension. This is maybe due to severe LV dysfunction, dynamic left ventricular outflow tract obstruction, severe right ventricle dysfunction, pulmonary hypertension, vasoplegia. When each trial of weaning trial should be end. If there is significant hypotension, if there is left ventricle or right ventricle distension, mean arterial blood pressure is then 65 millimeter mercury, weaning trial should be stopped and we should return to full ECMO support. Transthoracic echo versus transesophageal echo. Which is better? As weaning assessment requires repeated measurement over several days, so if the images are clear and easy acquired by transthoracic echo, it will be better. As transthoracic echo, we can get left ventricular systolic function and left ventricular flow and right ventricular diameters. But if we have problem in taking a picture through transthoracic echo, as there is poor echogenicity, we can go for transesophageal echo. Here's simple summary for recommendation for successful ECMO weaning. First step, the etiology of cardiac failure is recovered. The second step is the patient is hemodynamic stable, and this is defined in previous lecture. Third step, the patient has good pulmonary function, and if the patient has PO2 over FiO2 less than 100 millimeter mercury, and if you used FiO2 from ECMO side at 21%, we can bridge the patient to VV ECMO. For this step, the patient should tolerate all weaning trials, and if any failed of these trials, like left ventricle and right ventricle extension, the patient didn't fulfill all these criteria for echo criteria mentioned before in previous lecture. So this is considered weaning failure and return to full flow. If the patient fulfill all of these criteria, we can go for ECMO removal. Decannulation is the last step after successful weaning. Before removing cannula, flow should decrease again and the circuit disconnected from the cannula, but can be circulated within the circuit. For peripheral cannulation, we should use ultrasound to examine the cannula site to exclude deep vein thrombosis. As we mentioned, if we have a problem in gas exchange and the heart is hemodynamically stable and fit for decannulation, we can shift VA ECMO to VV. This case of VA ECMO decannulation, here we can see this is the venous cannula, and this is the arterial cannula, and here is the reperfusion cannula. First of this, first thing, the patient has stopped anticoagulation, and we check ST before the step of decannulation. Then the patient is on full sedation and muscle relaxant. The ventilation and inotropic support are optimized. Then after that, they clamp the circuit distally, and they will start by first they will remove the venous cannula by doing the sutures all around, taking persistent sutures and tied strongly and tied together. And one of them will take off the cannula outside and the other will compress to avoid bleeding. After removing the cannula, they should be sure that blood come out, to be sure that blood will come out and there is no thrombus left inside. During the removing or during decannulation, the patient is fully monitored on the monitor. We can take video capture for the monitors, as I wanted to concentrate on how they take the sutures around the cannula. These cannula are inserted percutaneously in the ICU, and they also will removed also in the ICU. Now they tied the suture together, make it tight them. This is one side, and that is the other side. They will make tie with them. One of the operators will tie it carefully, take multiple ties to be sure that the opening of the vein is strictly tight, and the other one take out the cannula. Now it's out, and they allow some of blood to come out during this procedure. Now they will compress strictly, and one compress with his hand and the other tight strictly to avoid any bleeding or hematoma at the site of the removal of this cannula. Then he will compress after time. Still compressing. One of them compress till be sure that there is no bleeding, and it's fit very well after it. Still compressing, and then now they will start to remove the second one. One will compress to at the venous side. The issue is you have problem because both of them at the same side, and the other they will start from to remove the other one. This the second part of the cannulation video. After they remove the venous cannula, now one of the operators are compressing at the cannula site to avoid formation of hematoma or bleeding from that side. And this cannula is the arterial cannula, where they will do the same sutures, persisting sutures, all around the cannula and tight firmly to remove the arterial cannula. This patient has a problem in the other leg, so they were obligated to put the two cannulas in the same limb. And now if we see the operators, they do sutures all around the cannula, and then now we will tie the two sides of the suture, two sides together, and strictly they will tie together, and then one of the operators take it out or take the cannula out from the artery. This blood is a good sign to ensure that there is no clot or thrombus occluded the artery. They will tie it firmly, and they will compress for about 45 minutes to be sure that there is no bleeding or re-bleeding from the cannula removal site. This is percutaneously inserted and percutaneously removed cannulas. After complete decannulation, we should check the limbs by ultrasound and by Doppler to ensure that there is arterial pulse distal to the limb. After weaning assessment, if both left ventricle and the RV and right ventricle are recovered, we can return to 50% of full flow till decannulation is scheduled. If the trial was unsuccessful, full flow is resumed till weaning trial repeated in 1 to 2 days. After weaning assessment, if biventricular failure persists, we can evaluate for artificial heart placement or heart transplant. If left ventricular dysfunction persists but RV function recovered, we should consider the left ventricle assisted device insertion. If right ventricle dysfunction persists but left ventricle function recovered, we should consider external right ventricular assisted device. Anticoagulation during the weaning attempt. ECMO weaning trials are associated with a risk of thromboembolic complication due to blood stagnation during the reduction of ECMO flow. At that time, we should know that activated BTT, partial thromboplastin time, should be between 1.5 to 2.5 times the normal value. If the patient has failure of weaning, maximum runtime of ECMO should be 7 to 10 days. If weaning failed, the patient should be shifted to different forms of mechanical circulatory support. Proceed with the decannulation without aim to recannulate. Push-off trials. If the patient had ECMO-related complication, we can maximize the inotropes and the ventilatory support. It should be at last resort to give the patient high conventional support. This can be done when we have intracranial hemorrhage or massive uncontrolled hemorrhage. Besides these references, I depend on also Red Book. It's very important in this topic. And also, I'm thankful for our cardiac surgery team for allowing us to capture these videos for decannulation. Thanks, and questions can be posted in the comment.